Good evening, everyone. We'll just give it a minute or two to make sure people have a chance to log in before we get started. Okay, I think we'll get started. Good evening again, everyone, and thank you all for taking the time to join us for our Ontario Sienna-wide resident and family town hall. The COVID-19 vaccines remain a big topic on everyone's minds, so we wanted to provide you with an opportunity to hear the most current information directly from our medical professionals. We hope the discussion tonight provides you with an understanding of the vaccines, the new variants of concern, and what we're doing as a company to continuously manage the situation and support our residents, our team members, and all of you. With so many participants on this webinar, we were not able to open it up to live questions. However, we did provide you with an opportunity to submit your questions in advance, and we received very many. So thank you to all of you who provided them. We took the most commonly asked questions and combined them into themes that we will go through, hoping to touch on most of the questions that are important to you. We did note that some of the questions were specific to individuals. And unfortunately, for privacy reasons and due to timing as well, we can't get into specific individual situations. So for anyone who did have a personal health related question that's related to the vaccines, we ask you to please reach out either to your residence team or to your personal care provider to determine the best route for you or your loved one. Now I'd like to introduce you to our guests for this evening. Dr. Andrea Moser is Sienna's Chief Medical Officer. She's a family physician with a focus practice in the care of the elderly, a certified medical director, and an associate professor with the Department of Family and Community Medicine at the University of Toronto. She has an extensive background and interest in the care of seniors with a focus on long-term care medicine and has been an advisor in the past to the Public Health Agency of Canada, among other organizations. At Sienna, Dr. Moser is focused on enhancing the medical and physician support provided to our residents, as well as supporting our management of the COVID-19 pandemic and preparing for any potential future outbreaks. We're also joined by Dr. Allison McGeer, Chief Infection Prevention and Control Consultant to Sienna. Dr. McGeer is the premier infection prevention and control specialist in Canada. She is a professor in the Department of Laboratory Medicine, as well as the Department of Pathobiology and Public Health Sciences at the University of Toronto. And she advises multiple levels of government on pandemic prevention and management, including Canada's National Advisory Committee on Immunization and the Infection Control Subcommittee of Ontario's Provincial Infectious Diseases Advisory Committee. You may have seen Dr. McGeer interviewed on radio, TV, and quoted in newspapers as she's a highly sought after expert in this field. With Sienna, Dr. McGeer has played an important role in guiding our teams to effectively manage outbreaks and prevent further spread of COVID-19 virus, as well as preparing sustainable plans for the future. Now we'll get into the presentation for this evening. And we'll begin with a brief overview from Dr. McGeer on some of the latest information regarding the virus and the vaccines. Over to you, Dr. McGeer.
Thanks very much, Maureen. Good evening, everybody. It's been there was a real high in January when the vaccines came and we finally started to be able to protect people. It's been a little more difficult for the last couple of weeks. I think maybe it's the combination of the darkness of February and the advent of variants. But one of the things that happens, there's been a lot of information about a lot of things come out in the past 2 or 3 weeks. So I'm going to do a fly through of some of the new information. I'm going to apologize ahead of time for all the biochemistry in it. Okay, this is because I am an ex-biochemist. So do try to remember your high school biology and be a little patient with me. So let's start with new vaccines. We've got 2 vaccines in Canada now, the Pfizer and Moderna, both mRNA vaccines, both in the short term in the trials, very effective in preventing disease due to SARS-CoV-2. And now we've got data on 3 more vaccines, the AstraZeneca vaccine, the Janssen vaccine, and the Novavax vaccine, different types of vaccines. Novavax looks as good as Pfizer and Moderna. When you first take a look at the data, AstraZeneca and Janssen don't look quite as good, but the studies that were done are different. It's really hard to interpret and to know whether there are significant differences. So we're going to have to wait for more data for things to sort themselves out. But at least at the moment, all of these vaccines look like they protect very well from more severe disease. And so it's probably not going to matter much which vaccine you get offered when vaccines get to you, because anything that we license in Canada is going to be something that works probably as well as any other vaccine. Next slide. Okay, so one of the important issues when you start a new big vaccine program is that you don't know when you start whether there are serious adverse events that can occur very rarely with vaccine. And you just have to wait until you've used enough vaccine, and enough vaccine is generally defined as 10 or 20 million doses, because you're looking for things that might happen once in a million or once in every 2 million doses, and you just need a lot of vaccine given. So one of the good things about COVID vaccines is, yes, we've been giving them, okay? And around the world, we're now up to more than 50 million doses of Pfizer and Moderna, and the only serious side effects we've seen are the allergic reactions. Anaphylactic reactions do occur. They occur to all vaccines and medications at a rate of about 3 per million for Moderna, about 5 per million for Pfizer. So they're rare, but they do occur. And that's why when you go and get your vaccine, people will make you wait for 15 minutes after the vaccine to make sure you're not going to have a reaction. And why immunization clinics all have to be ready to deal with a serious allergic reaction when they give a vaccine. If you're deeply into safety of vaccines, you'll look at that link at the bottom to the American Advisory Committee on Immunization Practices. You can actually look at the American system for monitoring adverse events to vaccines and understand just how much work public health officials put into monitoring for serious adverse events to make sure that they're not happening. So this is really good news for Pfizer and Moderna, and now we're waiting to see what happens with the other vaccines. Probably get it before we get them in Canada. Next slide. Okay, one of the things that people have been a little worried about is dealing with the immediate adverse events of these vaccines, because people have talked about them as really being associated with a lot of side effects. So the important thing to know is, yes, they are associated with local side effects. They mostly occur in the day after. And so think about 3 vaccines for a moment. There's flu vaccine, there's COVID vaccine, and there's Shingrix, the vaccine against zoster. Pfizer, the COVID vaccines, the Pfizer and Moderna COVID vaccines are between flu, which really only has a sore arm as an adverse event, and the inactivated vaccine against shingles or herpes zoster, which has about a 20 or 30% risk of really feeling punk the day after you get the vaccine. So despite the fact that people talk about how bad these reactions are, you really have to look at what the differences are between people who get placebo, because when people get placebo in a trial, that's what happens in life. So you will notice that in the first dose of the Pfizer vaccine here, you can see that in the week after people got vaccine, 13% of them had a headache, 13% of them had fatigue, and 12% of them had a headache. And so a lot of people after they got vaccine had fatigue and a headache. It's only 2 in 100 difference between the people who got placebo and the people who got vaccine. So the answer is that lots of people get headaches in any given week, and about 1 in 50 people get a headache from their vaccine dose. So you need to separate out a little bit what it is, but you can see here that after your second dose of vaccine, you get more adverse events. About 1 in 20 people get a fever. About 40% of people feel unwell the next day. And about 1 in 5 people get muscle pain and joint pain. So you do want to get the vaccine on a day when the next day you can take a bit of a break, but generally it's only a day that these adverse events happen and everybody recovers from them. So it's not a reason not to get the vaccine and protect yourself from COVID. Next slide. Okay, now let's talk variants. Okay, this is the hard biochemistry part. All right, up in the top left corner is a picture of a coronavirus. Coronaviruses are called that because they have a crown around them, and that crown is composed of spike protein. Proteins, back to grade 12 biology, are made up of long chains of amino acids, and each amino acid is charged differently. So when you put them together in a line, the protein folds depending on the charges on the amino acids. And in the center right, is a picture of a spike protein. The top piece is the piece that sticks out of the virus and causes the crown. And those yellow, kind of yellowish green, windy things are the area where the virus spike binds to the cells of your nose and throat and cause infection. Viruses change all the time, and when their RNA changes, some of the time that change in the coding in the RNA means that the RNA codes for a different amino acid in a particular place in the protein. And that different amino acid then changes the shape of the protein. So looking at this figure, you'll see 2 things labeled up near where the spike protein binds your respiratory tract, something called Y501 and something called K484. So that's position 484 and 501 in your long chain of proteins, amino acids that makes up this protein. And those 2 positions are positions that have changed in the UK variant and the South African variant of this, of the virus. So it goes from a baseline to a different amino acid in 2 positions that are very close to the binding site. When those amino acids change, the spike protein changes shape. And the way it changes shape, we figured out, is that it binds better to the cells of your respiratory tract. And that's why we're so worried about these variants coming to Canada. This is an ongoing process in coronaviruses as it is in influenza viruses. We're going to see more variants coming. Hopefully we'll get better names for them and countries. We're not supposed to be naming viruses and variants after countries, despite the fact that we're kind of doing it at the moment. But we are going to have to watch as these proteins change and as it changes how infectious the virus are. So now let's talk implications of these variants. Next slide. Okay. The first variant that we're going to see that we're really worried about is called the B117 or the UK variant. We had none of it at the end of November, despite the fact that it started in the UK first recognized in September, and very little of it at the end of December. But we're clearly seeing increasing numbers across Canada, and we're now at about 200 cases identified in Ontario. One of our problems is that when you hear the stories in the media now, people are talking about the number of cases as if it's a real number of cases. But the truth is that we haven't been able to test every virus. We're not even close to being able to test every virus. So all that the number of cases is giving us is a sense of how quickly it's increasing. And it's looking like There was none of it at the end of December. By the third week in January, it was in really small numbers, about 2%. Now it's probably about 10% of all viruses. So it's growing pretty quickly. And the pictures across the bottom, that map of England in different colors, shows you what happened in England. So at the end of November, most of the northern part of England was white. So if you look at the color chart on the right-hand side, that's at less than 5% of their variants of their viruses were the UK variant. By the time you get to the middle of January on the right-hand side, most of England is dark purple, so above 75% of all the variants with the UK. And that's what happens. This is a more transmissible, more successful variant, so it just takes everything over. All the other viruses die out, and you just get this variant. The good news about the UK variant is that vaccines, particularly Moderna and Pfizer vaccines, but generally all vaccines work well. So that's a nice thing. But the bad thing about it is that it's more transmissible. Next slide. So let's talk for a minute about what that means in terms of what we have to be able to do in Ontario. On the top part of this slide is a graph of the number of cases of COVID reported in Ontario from the end of January last year to the beginning of February. Oh, I've kind of lost the measure on this. Sorry about that. They were supposed to line up with each other, which they're not doing perfectly, but that's okay. And on the bottom part of it, you see what's called the reproductive ratio. The reproductive ratio is the number of new cases generated by an individual case. And the line in the middle, that line of 1, if your reproductive ratio is 1, then each new case generates a second case, and you stay at exactly the same number of cases every day. When your reproductive ratio climbs above 1, cases start to increase. And remember that it's multiplicative, not additive. So your cases don't go 1, 2, 3, 4. If your reproductive ratio is 2, your cases go 1, that generates 2 cases. Each of those 2 cases generate 2 cases, that's 4. Each of those 4 cases generate 2 cases, that's 8. So it goes 1, 2, 4, 8, 16, 32, and you see the curve that you see at on the top of the number of cases. Even though our reproductive ratio was holding steady at about 1.05 or 1.1, you see this increasing number of cases. And it gets worse and worse and worse. The curve gets steeper and steeper until you can pull the reproductive ratio back below 1. So in January and February, on the right-hand slide, you see the reproductive ratio drop below that gray line. Doesn't have to drop dramatically to have a big impact on cases, but we're now running at just above 0.8. And that means our cases are declining really well. The challenge is what's going to happen to that reproductive ratio when the new variant comes. Look at the next slide. You'll get a sense of what's going to happen. Okay, it's a really complicated slide, so forget the colors on it and just look with me at the size of the dots and the triangles and the diamonds on that graph. This, again, is a map of reproductive ratios, so that the diagonal line in the middle is what happens with a reproductive ratio of 1. And you can see that all of the dots that are smaller are closer to 1, and everything that's bigger is further away from 1, it's up close to 2. And the big dots, triangles, diamonds, the larger the diamond, the higher the percentage of cases that were due to the UK variant. The smaller ones are due to the regular old virus. So with the regular old virus, at the time this graph was drawn in November in the UK, their reproductive ratio was above 1. It was running about 1.3 or 1.4, which wasn't great. But where they had the UK variant, they were up at 1.8 or 1.9. So our 0.8 reproductive ratio with the regular virus is probably going to be about 1.2 or 1.3 with the UK variant. And that, of course, is a problem. So we're going to have to figure out how to do better so that we can pull the reproductive ratio down to 1 or something maybe a little bit higher, but very close to 1 when the new variant really takes over in Ontario. And so that's the challenge ahead of us for all of us for March. Next slide. Okay, so what are we going to do about this? How are we going to face this? And people's approaches to it have been somewhat different. In the United Kingdom and most of Europe, they've really worked to improve adherence to public health interventions, to say to people, you know, we just need to get through until we have more vaccines available, until spring comes and we can start opening windows and opening doors. In much of Europe and in the UK, they've had to close schools and increase the strength of lockdown. So we might be facing that come the middle of March in Ontario. And in some countries, people have moved to recommending that people wear medical masks in the community. So we're going to hear a lot of discussion in the next few weeks in Canada about what kind of masks we're wearing and how we're wearing them and what we ought to be doing with them, because they are one of the important things in preventing transmission. In Canada, there's still really no firm consensus at the moment about what we need to be doing. So you will see different provinces and different public health units responding differently at the moment. In areas where we've been worried about variants, the public health units have implemented added precautions in outbreaks, and sometimes just in high-risk areas. So there's going to be a lot of differences in what people are recommending, particularly if any outbreaks happen in the next few weeks that we're going to have to live with while we talk about this. And we've been having a serious discussion about whether we need better fitting masks, whether we need medical masks for everybody, whether we have enough medical masks for everybody in the community, whether we can recommend to people that the way they're wearing their masks is better so that they fit better and they'll give us better protection. I think you're going to hear changing recommendations over the next few weeks as we try to figure out how to do the best we can with this variant, so that we don't have to go too far into lockdown while we're waiting for vaccines to kick in. And I think that's the end of my slides, Maureen, so it's coming back to you.
Okay, thank you. I'll just turn it over to Dr. Moser to talk a little bit about what we're doing and what we have been doing in some of our communities in Ontario. Dr. Moser?
Thanks, Maureen. I think I'm sensing the feelings in the chat coming through of really people wanting to know, when are we getting vaccine? When is it coming to our communities? And I just want to let you know that we're working very hard to make sure that we're prepared for it so that when it is available, we're able to move. I see many of the facilities listed where they haven't had vaccine yet. I know the staff in those facilities have been actively getting consents from families and residents so that when we're told the vaccine is available, we won't have any delay. It is out of our hands, and we are in constant communication with public health in those areas to find out when we'll be getting it. So in order to speak to this slide, what are we doing? We're really keeping on track of that vaccination and making sure that we get the information out to people. If there's any question about vaccine, we answer those questions, because this is really our key to preventing widespread spread and outbreaks in our facilities. And then we're also really making sure that we're not letting up on our infection prevention and control, that word IPAC that we've all heard so many times in the past few months. It's really important. We're all tired. We've been doing this for a year. And it is hard to do this. It's hard to always wear a mask. We get tired of doing it. And with vaccines present, we have to make sure that we're not letting our guard down. So even with the vaccine, we still have to do that rigorous IPAC measures. We are using the face shields for direct care providers and essential care providers. We're also doing more enhanced cleaning of some of the areas that you touch a lot, like the doorknobs, the hallway railings, tabletops, those types of things. And then we're continuing to do active screening of all of our team members, all of our visitors. We have to still prove a negative test, a COVID test, to come into the facilities, and that's for all of our team members and for the essential caregivers. And then we're going to be starting to do some rapid testing. So you're going to see in the coming weeks that we're going to be starting to roll out into the communities as advised by the government, the rapid testing. And that's going to be quite a shift for us. And it's also going to be quite a shift for you if you're coming into the care community. And that's going to be 2 to 3 times per week for team members. And every time an essential caregiver or visitor comes into the home, you'll be asked to have a swab right on the spot. And you'll have to wait for the result of that, which takes about 15 to 30 minutes before you're able to go up on the unit and visit your loved one. So more will be coming out on that. I know there's some communication happening over the next few weeks, and we'll be continuing to update people on that. Okay, Marie?
One more slide here.
And then if we do go into outbreak with one of these variants of concern, we're going to be getting it sounds like some changing guidance coming from public health. We've had one experience with this already. And already, as I think public health, the word they said was building the airplane as we're flying it, because the variants are new to us and we're learning about them quickly. A little bit more cohorting in terms of making sure that are really enforcing that our staff, if they're working in a facility that has one of the variants of concern and it's in outbreak, the strict measures of come to work and go home, don't go anywhere else. You change your clothes when you come into the building and change your clothes when you leave the building. All of those things that we're doing, really making sure we're keeping our staff on non-outbreak areas separated from staff that are on outbreak areas. And also really trying, if at all possible, that if the residents are positive with COVID, to give them a mask as well as give the caregivers a mask when they're providing care. And that can be really hard for some of our residents. So it's not something that we can force, but we can really try to encourage it with the residents who are able to wear that. And then again, more cleaning. When we have an outbreak in our communities, we bring in more staff. We bring in more PSWs for personal care. We bring in more nursing staff. We also bring in more environmental cleaning staff so that they can do continuously cleaning, continuously restocking our PPE caddies and keeping all of those things going. And then we're in constant contact with public health. So when we have an outbreak, we're on calls with public health every day, and they're advising us. They're coming on site. People from the region are coming and doing inspections as well. And they give us the guidance on what we need to be doing, and we follow those directions from public health.
Okay, thank you. So now we'll get into your questions. And once again, I know some of you are putting questions into the chat. I think we may be able to get to those as we move along, but really we're focused on the bulk of the questions that were submitted in advance, which do reflect some of the other ones you're typing in tonight. So we hope that collectively we will be able to capture all of your questions. So Dr. McGeer, you did talk a little bit about some of the long-term effects and the vaccine safety. Here are a few specific questions that people asked. Can we feel confident about the long-term effects of mRNA vaccines? Can you discuss any possible adverse reactions, which I think you did cover already? And how are residents monitored after getting vaccinated to ensure their safety? So Dr. Moser, you might be able to touch on that last point, but can we start with you, Dr. McGeer?
Yeah, for sure. So mRNA vaccines, like all vaccines, it's a little bit like taking a medication like Tylenol or aspirin. You get an effect when you take it. It lasts for hours or a day or so. And mRNA vaccines stimulate the immune system, so you feel the adverse effects of your immune system kicking in and responding, but the vaccine itself is then gone. So the mRNA is very unstable. Actually, the big problem was getting it stable enough to actually get into the cells and make it work. And so vaccines don't have long-term effects. They clearly do have short-term effects, and the allergic reactions can be serious. And there are some vaccines that have effects because of the immune reaction in the first few weeks after you get them. This does not appear to be true with the mRNA vaccines so far. None of those potential effects have been detected, but it can happen with some other vaccines. But there are no long-term effects. So something is not going to happen to you years from now as a result of getting any vaccine. One of the good things about vaccines.
Okay.
I think in the teams coming into vaccinated homes, generally speaking, they come in as a group and the residents come down to be vaccinated. And just as the rest of people do in the clinic, they wait for 15 minutes where they're observed before they go back upstairs. And that's because if you're going to get a serious allergic reaction, it almost always happens within the first very short period of time after vaccination. So it's a routine requirement that people be observed after they're getting vaccinated for that period of time.
Okay, great. Do you have anything to add, Dr. Moser?
I think just around the monitoring. So we know what our experience to date has been after the first dose. Residents are having a little bit of a sore arm and occasionally a fever or just not quite themselves the next day, but it's really quite mild. And then I think, as Dr. McGeer had said, after the second vaccine, we're seeing a little bit more robust reactions in terms of or symptoms in terms of they may have a fever and again a sore arm or a headache, and the nursing staff are monitoring for that, and the medical staff are aware of that as well. So we're making sure that when there is a second vaccine clinic at the home, the teams are aware of that and they're on the lookout for those side effects. So they're watching those residents carefully, and if they have a fever, they'll give them Tylenol, and that's perfectly safe after having had the vaccine. So that's what we're working on. And if there's a severe reaction, like Dr. McGeer spoke about, the allergic reactions, those are ones that we actually would report. There's actually a reporting mechanism with the vaccine rollout that all of the homes are educated on as well.
Okay, thank you. Next slide. So the next one is around eligibility. You may have touched on some of this earlier, Dr. McGeer, but wondering, who is eligible to receive the vaccine? People, how does it relate to anybody who may have had COVID already or hasn't had it at all, or if they have any other health concerns or other, pregnancy or any of those things? Who's eligible out of that kind of general pool?
Yeah. So let's start with the top of the questions. If you previously had COVID, it is still recommended that you get a COVID vaccine. You likely have some protection for the first few months, but we don't know how long it lasts. And the vaccine will give you better protection for longer. Public health people have said that is a sensible precaution to take when you've already had COVID. If you currently have COVID, there's a recommendation that you wait until you have recovered from it. That's for two reasons. The first is that you don't want to mix up what might be adverse effects from the vaccine with something happening to your COVID infection, and just make sure you're separated from it. The other thing is that when you have a significant infection, you're going to get more severely ill. You may not respond quite as well to the vaccine, so you're better to wait until you're over any significant infection before you choose to get vaccinated. That does not apply to people who just have a runny nose or feeling a bit off. We've done lots of studies with vaccines to make sure that people respond as well to the vaccine when they have a cold, and so there's no reason to not get the COVID vaccine if you have a cold. Now, mind you, if you're an essential caregiver, staff person, and you have symptoms of a cold, you're not going to be allowed inside a vaccination clinic or anywhere else. You're going to be home self-isolating. So at the moment, that's kind of an irrelevant question because you have to be well in order not to be in self-isolation. People taking immune suppressing drugs may not respond as well to the vaccine as other people. And initially, Our National Advisory Committee on Immunization said because they might not respond as well, we perhaps should not be vaccinating them routinely. But we also know that people taking immunosuppressant drugs are more likely to get seriously ill if they get COVID. So there's a reason to vaccinate them. You need to know if you're taking an immunosuppressive medication that you might not respond as well to the vaccine, and that we can't tell you how well it will protect you. But we believe that it will provide enough protection that it will be of benefit to you. And so it is generally recommended that anybody who is immunosuppressed also take the COVID vaccine. People with severe allergic reactions are at increased risk of an allergic reaction when they get the COVID vaccine. So about 75% of people who've had severe allergic reactions to the vaccine are people who've had allergies before. But that risk is still low relative to the risk of getting COVID and getting seriously ill from COVID. If you have had a severe allergic reaction before, you will get asked that when you go to get vaccinated, and you will likely have to wait in clinic for 30 minutes instead of 15, just to provide an extra layer of protection in case the allergic reaction is a little bit delayed. But again, your risk is maybe something in the order of 1 in 10,000. It's a bigger number than the 5 in a million, which applies to the general population, but it's still a pretty low number. And every vaccination clinic is prepared to deal with allergic reactions. So it's a manageable adverse event. We are not worried about people who are breastfeeding getting COVID vaccines. The COVID vaccine does not get into breast milk, will not affect a baby who is breastfeeding. We are still being a little bit concerned about pregnant women. We worry about everything in pregnancy. So even there's no reason to think that a COVID vaccine in pregnancy would be dangerous or cause adverse events, we're not going to recommend them routinely until they have been tested in pregnant women and we are absolutely sure about it. On the other hand, people who are pregnant are still living their lives and are at some risk of COVID. And so the public health recommendation now is that anybody who is pregnant should be talking to their care provider about whether what their risk of COVID is and what the potential risk of the vaccine is, and balancing that out and making their own decision about what they want to do. So obviously lots of staff and team members who work in our long-term care homes are pregnant, they're thinking about getting pregnant. So this is a significant issue for many staff in long-term care and retirement homes.
Okay, thank you. Next slide. So looking at the timing and the process for the first vaccine dose, do you have any insights to share on when retirement residents will have access? I know Dr. Moser referenced a lot of some of this earlier with regards to the vaccine arrivals being out of our hands, but any insight you can provide? When will essential caregivers have access and the general public? And do you know when or where the vaccinations will take place? Dr. Moser, would you like to start with that?
Yeah, so we're just, I mean, we're waiting as much as you are. We have about 30% of our residents in retirement across the province of Ontario have had first dose of the vaccine. But a lot of the homes haven't seen any vaccine. So we really are waiting for when the vaccine arrives and the public health departments and the hospital partners are able to get that vaccine to us. Essential caregivers as well, we're waiting on that directive and on vaccine availability. And general public as well. So we know that the long-term care homes are prioritized, the retirement homes are prioritized, and then after that, there's a whole series of the next prioritization groups. And the general public, it's going to be coming over the next following months, but it's not going to be tomorrow. And it's really going to be based on vaccine availability and the ability to set up the clinics to get the vaccine out there. So I think everybody just has to really pay attention in their area and find out, listen to the announcements, connect to your primary care provider as well if you know that you want the vaccine. I don't know how many people are looking at lists of people who may be available. And then when and where the vaccinations will take place. So with our retirement homes and our long-term care homes, the vaccinations are taking place now on site at the homes. Initially with the Pfizer, because they were in the hospitals, our staff were going to the hospital clinics to get the Pfizer vaccine. But now with the Moderna and the Pfizer, they are mobilizing it out. In the community, I actually don't know at this point how the vaccinations will be occurring in different communities across the province. And Dr. McGeer, you may have more information on what that might look like.
I think, you know, in the background, the vaccination program is being run by the province with the help of public health units and a whole lot of other people. And there are large numbers of people working really hard to try to make sure that we run this efficiently and effectively with the restrictions that are necessary for the vaccine. So I think we had a deadline for getting retirement residence done, and then we got into trouble with not having enough vaccine, and everybody is I think upset about the fact that that's had to be a slowdown. You know, I think the best I can tell you is people really are doing their best to get it out to as many retirement residences as possible. When we get to the general public access to vaccines, I think we will be doing it in 3 ways. There will likely be some large public health run clinics. Those of you remember H1, 2009 H1N1, you see them because that's an easier way to manage the Pfizer vaccines, but we're also going to need a lot of help from everybody. So it's likely that both pharmacists and family physicians will also be delivering vaccines. I think the challenge is, a piece of it is we don't know which vaccines we're actually going to get and in what kind of numbers. And so figuring out how we're going to manage the distribution's been really difficult. But I promise you there are a lot of people working on it, and you know, they really are going to be doing their best to make sure that every dose of vaccine that comes in is out and into people's arms the moment it gets to the province.
Thank you very much, both of you. I just want to go back to on the first questions around safety. There was maybe a different way of interpreting some of those questions, and wondered if you could provide some insight on the long-term effects of the positive long-term effects of the vaccine, and whether it would be you know, a 1-year effect, or if it's an annual vaccine we're going to have to get, or if you can provide some insight on that, Dr. McGeer.
Yeah, for sure. Well, I can provide maybe some insight, but not answers. You know, how long these vaccines last depends on 2 things. The first is how quickly the virus is changing, because it's beginning to look like this might be a virus that is like the influenza virus, where you have to keep updating your vaccines because you have to keep adapting to changes in the virus. But we also don't know with these vaccines how long the protection lasts and whether it might fade after a year or 2. You know, there's some vaccines that last a lifetime, like measles and hepatitis B. And there are other vaccines like pertussis vaccine where you need, and tetanus, where you need boosters periodically. So when you start a vaccination program, you never know how long a vaccine is going to last. It's much more obvious with COVID than it is with most other vaccine programs, but it's always the way. And so we're going to be watching very carefully what happens over time while we think about whether this is going to turn into something where you have to get a vaccine every year, or whether it turns into something where you might just have to get 1 or 2 shots and they'll last you for the rest of your life. The good news is, I think that now we have vaccines, we can adapt to it. So if we have to get a vaccine every year, what we'll probably have is a COVID and flu vaccine together. So it'll still just be 1 shot. It's just you'll be getting COVID and influenza vaccines at the same time. And we can still hold out hope that, you know, you'll just need 2 or 3 doses and you'll be ready for the rest of your life. But either way, we can cope with it.
Okay, thank you. So maybe we can go back to where we were in the questions.
Yeah, and I just want to clarify, Maureen, for the essential caregivers, we are essential caregivers are in the prioritized group as well. So I just wanted to clarify that. I think I had that wrong.
Okay. Oh,
Yeah.
thank you.
And we have been vaccinating essential caregivers.
Okay.
I think if you are
Um,
essential caregiver, make sure that your home knows that you want to be on the list, that you want to get the vaccine, because what's happening with some staff and essential caregivers are getting vaccinated when clinics come to homes, and some of them are still going to the hospital clinics to get vaccinated, and homes are being offered spaces at unpredictable intervals in the hospital clinics. So if homes know who's on the list, then they make sure that all of their spaces are filled when spaces open up. It's just that there's not a lot of warning that they get for it, and so it's good if they know ahead of time. So do have a discussion with your home if you're an essential caregiver about, you know, what the process is and what they need from you, so that they're sure that you're on the list of essential caregivers to get vaccinated.
Okay, thank you. So moving on to the next topic is vaccine delays. So people are wondering, will the vaccine delays impact when resident staff or essential caregivers get their first or second dose? I think we've kind of touched on that in some of the responses already. Will a delay in getting the second dose impact its efficacy? And what is the safe period of time between the two doses of the vaccine? Is that something, Dr. McGeer, that you can speak to?
Yeah, for sure. So there is some possibility that vaccine delays will impact when people get their second dose. The province at the moment is focused on trying to make sure that residents in long-term care get their second dose on time, because residents are older and frail, they may not respond as well to the vaccine as the rest of us, and they might actually need their 2 doses for good protection. For the rest of us, which includes anybody who's living in the community up to about 80 years old, which is the age of people who were in the trials, it's clear that about 2 weeks after your first dose, you are very well protected in the short term. And the short term is defined as out to at least 8 or 10 weeks after that dose of vaccine. And in fact, there's pretty good evidence from data from a whole lot of vaccines that it's better to get a second dose of a vaccine later rather than earlier. You get a bigger boost in your response if there's a longer period of time between your first dose and your second dose. It's not how we designed the COVID vaccines, because we thought that you were going to need 2 doses of a vaccine to protect you. And we wanted those 2 doses to be given as close together so we could get protection to people early. As it turns out, however, 1 dose of these vaccines gives you really good protection in the short term. So it's, despite the fact that we're giving it to people on time, it actually might be a little better if we gave it to you later. And generally speaking, there's no outer limit to how long it can be between 2 doses of vaccine. So there's a short-term limit. You shouldn't give vaccines less than 21 days apart. But you can give a vaccine 4 months or 5 months or 6 months later, and you don't need to restart, and it will be fine. So we may have some delays, although we're trying not to. But if there is a delay in getting a second dose, it's nothing to worry about. We will be getting second doses to people in enough time to be okay.
Okay, thank you. And on to the next slide. So after the second dose, I think, again, you did speak to this in your presentation, I believe, Dr. McGeer. Are there more side effects after the second dose? And I think both of you actually have said that, yes, it can be a little bit more pronounced. Can you still be infected with COVID-19 after both doses? And can you, COVID-19, it's, I think maybe a similar question, either still be transmitted by someone, or can it be carried by somebody who has received the vaccine? And how long are you protected after the second dose? So I think maybe we've just answered that question a minute ago as well. So Dr. McGeer, can you speak to that?
So the answer is yes. You notice that for the Moderna and the Pfizer vaccine, the protection is 95%. That leaves 5% of people who are still maybe going to get infected. You know, if 100 people were infected before, now 95% of them won't get infected, but 5% will. We think the evidence so far suggests that those infections will not be as severe as they would otherwise have been, but you can still get infected. So there are still going to be people who get sick and who test positive after they've had vaccine. There's just going to be a lot less of them than they were. So when you hear about somebody who got COVID after their 2 doses of vaccine, that's expected. Okay, we've given, I don't know, several 100,000 doses of vaccine now across Canada, and some people are going to get sick with COVID after they've had 2 doses. The third question is a really critical and very frustrating question at the moment, because when we test vaccines, usually we're most interested in whether they can stop people from getting sick. And those are the phase 3 trials that were done for our COVID vaccines. Do they stop you getting sick? And the answer to that is yes, very well. But what we don't know from those studies is whether you can still get a very mild infection, not have symptoms, but be shedding the virus and transmit to other people. And so we're working on collecting that data, on finding out whether or not that's true. But that's why, even though we know people are protected from infection and serious illness if they get the vaccine, we're still saying to people who've had their vaccine, you need to adhere to all the public health measures still, because you might still get an infection that isn't associated with symptoms, but could result in disease transmission to other people.
Okay, thank you. And the next question is around variants of concern. So do the vaccines work against those variants? Does the rapid test identify the variants? And if you've already had COVID-19, can you get one of the variants as well? And what is it that makes the variants more transmissible? So I think on that last point, you might have touched on that in your presentation, Dr. McGeer. Are you able to speak to the other questions?
So it looks like the mRNA vaccines work well against the variants, although they may not be quite as good against the South African variant as they are against the United Kingdom variant. Some of the other vaccines, you can see a bigger difference. They don't protect as well against the South African variant. All of the vaccine manufacturers are at the moment working on a new vaccine that will have a different spike protein in it to work against the variants. So you can expect over the next few months that we will be changing vaccines to make vaccines that work better against the variant, but that is at least 2 or 3 months away. The rapid tests, yes, can identify variants. They can't distinguish between a variant and not a variant, but if you're infected with a variant, you will test positive just the way you do with the regular virus. And yes, one of the concerns is that because these variants are different, the protection that you have from being infected with COVID-19, like the vaccine, may not be quite as good against the variants as it is against the regular vaccines. We still don't know that. We don't know how much of an effect there is, but we're expecting that there is an effect.
Okay, thank you. And the next slide, please. So will the vaccines be mandatory, or are they mandatory, or will they be? Are team members declining to get vaccinated, and how are you motivating staff to get vaccinated? Dr. Moser, can you speak to those questions?
Sure. So right now, the vaccine isn't mandatory, much as what we see with influenza vaccine every fall. We encourage people to take it, but it's not mandatory. We do have some team members who are declining or what we're calling vaccine hesitancy. They're waiting. They're not sure if they want the vaccine or not. So we're doing a lot at Sienna, like we're doing tonight with this webinar. We're doing similar webinars with our staff members. We have a special app on the phone that we communicate with our staff members on, and we're doing things, sending out little clips of myth busters around the vaccine. Our leadership teams in the homes are also talking to the staff in the homes and giving them education. There also are some groups provincially and nationally that are also working on how to address vaccine hesitancy in the staff. So we're feeling pretty good right now. I think I just checked across all of our care communities. I think we're up to about 60% of our staff have had one dose of the vaccine in our long-term care homes. A smaller number in retirement, but again, that's because the vaccine isn't available and in the same way in the retirement homes yet. So we're keeping on it. And we're the good news is we're well over 90% of our residents and staff, residents in both long-term care and retirement home are eager to get the vaccine, and that's really critical. So, you know, we get all of the residents we're caring for in our homes vaccinated, and then we get that herd immunity that really provides that protection and reduces the risk of spread.
Great, thank you. Next questions for the rapid testing. And I think we've seen, Dr. Moser, lots of questions coming through the chat about this as well. So will we be implementing this? We did touch on that earlier. Will it help to open up the residences for visiting sooner? And I think that I've seen several questions in the chat about is rapid testing replacing or in addition to the regular surveillance testing that people have been getting. So do you think you could answer those?
Yeah, for the most part, the intent of the rapid testing is that it's going to be replacing the PCR testing or the testing that you're doing now. That is only if you're asymptomatic, if you have no symptoms at all. If you have symptoms that could possibly be COVID, you still will be required to have what we call a diagnostic test, which would be the type of testing that you're having now. Anybody who's coming into a retirement and long-term care home, we believe retirement, but we only have the directive for the long-term care homes right now, will require that rapid test when they come into the building. And then you'll have to, like I said, it's a 15-minute or so wait. So you can anticipate adding a few more minutes onto your visit before you're able to go up to the floor. And that's what would happen. If you have a positive test from the rapid test, then obviously you wouldn't be allowed to enter or to stay in the building, and you would have to go and get a follow-up test to confirm that that was truly positive. So more to come. It's rapidly unfolding. Pardon the pun on the word rapid, but we're having to set up clinics. We're training our staff on how to do this test. We're learning all of the intricacies of setting this up so that it's done properly and safely, and more to come. You're going to hear in the next few weeks. The goal is that by mid-March, this will be up and running in every long-term care home that is not in outbreak in the province.
Okay, thank you. Next slide. So after vaccination, I think this is more, return to normal. What does that look like? Will our residences be more flexible to visitors and with protocols? Will residents be able to leave their rooms and dine in the dining rooms and participate in all of those activities? And will residents, team members, and visitors still need to social distance and wear masks? And then do you think that the COVID testing will still be required? So a lot of questions there. Maybe Dr. Moser, can we start with you and then we'll move over to Dr. McGeer?
Sure. So right now, the protocols for visiting homes is really we're being directed by the province on what that looks like. I think we've all heard that there's some areas moving to green. And what does that mean? Will there be a change in visiting in long-term care and in retirement? Right now, everything isn't really going to change with vaccination until we start seeing a real impact and decrease in outbreaks and high vaccination rates in the community and no more community spread. So because we don't know whether if I've had a vaccine, I don't know if I could be in that 5% of people who might be able to, who might get COVID and then could spread it to others, my family members, as well as residents that we're caring for and team members. So we really have to keep that infection prevention control going and going strong. And it's hard because the inclination, if you have a vaccine, you think, okay, well, it's okay now, I can do all these things. You still have to follow all of these practices that are in place. And that's the same with our residents. So really trying to the social distancing, the hand hygiene, the masking, all of those things are critically important, and we're just going to have to keep going. We would all love to go back to where we were, I think, last February. It's hard to believe it's been a year, but we just can't now. We're getting close. It's getting better. We're all eager to do things. I could tell you the list of things that I want to do and all of the family members that I want to go and visit, and we just can't do it yet. So we just have to be patient. We've been in this for such a long time. We're going to get through it, but it's going to take more time. So yes, we still need to socially distance. We still need to wear masks, and that's for all of us. And the weekly COVID testing is still going to be required. Again, we don't know who might be that person who has a positive COVID test after having vaccination. And we just really want to make sure that we're doing everything possible to reduce the risk of COVID entering our buildings. Dr. McGeer, do you have anything to add to that?
Yeah, my short answer to that is yes, but not soon enough. People at the province are very actively working on how we might make a staged return to normal. I think the introduction of the UK variant and the possibility of the South African variant has kind of caused people to take a deep breath and worry about that. So we are going to have to wait. First of all, we're going to have to wait until people get vaccinated, because we're having trouble with that already. Once we have people vaccinated, then we need to wait and see what's going to happen with the variant strain, and whether we're still going to have outbreaks, albeit maybe less severe, in long-term care, and whether we still need to keep up the precautions. So it is very clear that the number of outbreaks in long-term care across Canada is going down, and that the number of new cases in existing outbreaks is decreasing. That's awesome, okay? And it's very promising about what will happen and when we can open. But we have to wait through the appearance of the variant to see what's going to happen with the variant, and we have to be really sure that opening is not going to start a new wave of outbreaks and serious illness. So yes, people are working hard on it. Yes, it will happen as soon as people can think it can be done safely. Yes, it is good if you are pressing for it, okay? Because we're all scared of COVID and we may not move as quickly as we should. So it's absolutely fine to be putting pressure on all of us to be getting back to normal and to be releasing things. But it's also really clear that we want to be doing that safely for residents and their visitors at the same time. So it's going to be, as Andrea said, it's going to be a tough 6 or 8 weeks with sticking with all these protocols until we get the vaccines done and we see what's happening with the variant. And then hopefully over that time, we'll be able to start slowly releasing the restrictions and getting back to something that is better. Maybe not normal for a while, but better.
Great. Thanks, Dr. Moser. Did you have something else to add as well?
I just saw in the chat, someone was asking about a little bit about my role at Sienna. So I'm the new, it's a chief medical officer, and a few of the nursing home companies have that role, and it's a permanent job. So I previously was working at Baycrest and joined Sienna mid-October. And my role right now has been really supporting the teams in working with Dr. McGeer and all of the partners around COVID management. But going forward, there's a lot of things that I'll be working on with the teams and with the medical staff, both in the retirement homes and the long-term care homes in Ontario and BC. So just thought I'd share that
Great.
at the end.
Yeah.
And
Thank you
very
very
thankful
much.
for the opportunity. And this was a great session tonight. So thank you all for coming out. Had a lot of people on the call, which shows the interest. And if I had a truck with a full of vaccines, I think Dr. McGeer and I would be out there driving it to all of the sites that haven't had it yet, but we just don't have that.
Please, yes. Yeah, and I think I've seen some comments in the chat about worrying about team members not getting vaccinated, and I think there have been a bunch of newspaper articles and media stories about people being reluctant to be vaccinated. I think it's really important to recognize that these were brand new vaccines with new technology, and lots of people have questions about them. It's good that people have questions about vaccines, right? We want people to have questions. And what I'm seeing very clearly is as people learn more about them, as we've used more about them, as we get more comfortable with them, that more and more people are happy to get the vaccine. And I think we're going to see what happens with staff vaccination in long-term care, but I actually think it's going to be very high, and I don't know that we need to spend a lot of time worrying about it. I also remember that we care a lot about vaccination rates for influenza in staff being high, because we are dependent on staff not introducing influenza into the facility because the vaccine doesn't work that well in residents. But we're hoping, and it's looking like these vaccines actually work very well in long-term care residents. And if the vaccine protects residents well by itself, then it won't matter how well protected anybody who comes into the building is, because each resident is going to be protected on their own. So you can have all sorts of people introducing the virus into the facility, but if 90% of the residents are vaccinated, they will be protected. So we'll see how things evolve, and people are watching this very carefully. But I'm really hoping that the evidence so far is going to hold up, that this is a vaccine, or these are vaccines that are going to work for our long-term care residents and our retirement home residents, and that we won't need to worry about people who are not vaccinated coming into the home.
Great. Thank you both so much for all of the information that you've provided tonight, and your answers, and ability to jump in with the chat as well and answer other people's questions. And thanks to all of you who took the time to attend tonight. We hope we were able to provide you with some good information. The recording from tonight will be available on our website after tonight. So if you have other friends or family members who would like to watch, they can do so. And we look forward to speaking with you again at some point soon. In the meantime, enjoy the rest of your evening, and thank you again.